So folks, we'll just give it a couple more minutes to let people join the session here, but if you haven't already, please make sure to type your name, title, agency, and email address into the chat box so you can be recorded as having been present for today's session. All right, I think we'll go ahead and get started here. Thank you all for being present for today's learning community session titled Connecting the Dots, Adverse Childhood Experiences, Trauma-Informed Care, and Substance Use. Just a couple of quick housekeeping items. Today's session is being recorded, so please make sure to keep your microphones on mute. If you have any questions, you can type them into the chat box or unmute yourself at the end of the presentation when the presenters are fielding questions. There will also be a post-training survey that the link will be posted in the chat box towards the end of the training session. But with that, I'd like to introduce Rebecca Goslin, who's the Director of Clinical Initiatives, and Christy Bolin, the Program Manager, both at the Colorado Association of School-Based Health Centers. And I'll pass it over to you, Rebecca, or Christy.
Great, thank you, Kevin. Hi, everyone. Thanks for joining us today. I'm going to go ahead and switch into screen sharing mode, if I can get that on there. I am actually not seeing that as an option. Kevin, do you know how I bring that up?
Yeah, is there not
there it is. There,
okay.
I got it. Sorry about that. Great. So we are hoping to address one of the learning activities that people said they were interested in today. My name is Rebecca, and I am the Director of Clinical Initiatives at the Colorado Association for School-Based Healthcare. And I'll let Chris, and just full disclosure, I am actually not based in Denver, so I'm in the southwest corner of the state working remotely. I live close to the Cortez area. So Christy, I will go ahead and let you give your introduction.
Sure, thanks Rebecca, and welcome everybody. We're glad you could join us today. My name is Christy Bolin, and I am the Program Manager at the Colorado Association for School-Based Healthcare, and I am in charge of our ACES work as well as some tobacco work.
Great. So today we are really hoping that you come away with a understanding of how the work on adverse childhood experiences and the implications for increased risk of substance use relates to expert work, and specifically to what you all can do in school-based health centers. So helping you understand what the role of various individuals in a primary setting is, and also what the risk and protective factor research says and how that impacts ACEs, as well as what you can do using expert skills to build these resiliency and protective factors as a way of preventing substance use concerns and mitigating that risk for later in life. So that is our aim for the day. With that, Christy, I'll let you go from there.
Sure, thanks. So I'm just going to highlight a few key takeaways from the CDC Kaiser ACES study. This is really the landmark study from the 90s that had the outcome showing that looking at how negative experiences in childhood impact health outcomes in adulthood. And I know a lot of you are probably familiar with this, but there's a couple of findings that we wanted to highlight. But essentially, this was a study that asked around 17,000 people about 10 different ACEs, falling into 3 categories of abuse, neglect, and household dysfunction. And some key findings we wanted to discuss a little bit and dive into were the most common ACEs across gender were physical abuse, which 28.3% of respondents reported. Second most common being household substance use at 26.9%. The third most common is parental divorce at 23.3%. Broken down by gender, household substance use was the most prevalent ACE for women at 29.5% of female participants reporting this. So the next slide, please. We wanted to talk a little bit about a conceptual framework for the ACES study. The findings show that there was a dose gradient relationship indicating that more adverse experience a person has, the more risk for poor health outcomes. One of these is increased risk for substance use problems in adulthood. And as we just highlighted, one of the most commonly reported ACEs is household substance abuse, making this really important to pay attention to when we're working with youth who are in homes at risk for exposure to this adverse experience, as well as at a developmental phase in life when substance abuse is more likely to start happening. So what's going on here is the ACES study ties into some important research on the neurological impact of trauma on the body, especially in the developing brain. And we have a video clip from a TED Talk by Dr. Nadine Burke-Harris, the founder of the Center for Youth Wellness and the current Surgeon General in California. If you have not watched her complete TED Talk, I encourage you to do so. She does an outstanding job of explaining why ACEs is a health problem that can and needs to be addressed. But we're just going to share a snippet of it here with you right now.
Affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know.
All right, I'll turn it back over to Rebecca.
So just to build on that little clip, and I'd reiterate what Christy said, if you do have 15 minutes in your day, sometime I think it's about 17 minutes long, the full clip from Dr. Nadine Burke-Harris really, in a very concise way, outlines a lot of the physiological going to the neurological level of how trauma seems to, and these toxic stress experiences in childhood, how they create the physical changes that lead to risks in negative health outcomes in adulthood. So if you get a chance to check out the whole video sometime, it's a really accessible way to get a quick summary of that. And taking that into your practice, we wanted to share out a little bit on the American Association of Pediatrics and some of their thoughts on how to use this information and these findings from the ACES study in primary care settings. So the AAP really endorses the use of primary care for children as a medical home model to help address the impact of toxic stress, and within that, they encourage screening of ACEs. So a really great example of that is Dr. Burke Harris is one of the founders of the Center for Youth Wellness. Their website has a lot of information on how they have implemented this practice. She is currently the Surgeon General in the state of California, and just this year for 2020, they've launched some pretty impressive initiatives to try to increase screening for pediatrics. So they're really a forefront leader in this, taking these recommendations and saying that this is a health issue, and that if we are going to solve this health issue, we need to address it in a healthcare setting. That is largely reflected in the AAP policy statement on toxic stress, and really saying that the medical home model offers an opportunity to build relationships and networks for support when you are talking about adverse childhood experiences with families, and that by addressing it early, rather than just screening in adulthood, we have the opportunity to mitigate the impact of some of these adverse experiences early on. And within that, also recognizing that it is not the responsibility of your primary care providers to fix these problems, that it becomes a safe place to have these discussions with families, to do the screenings, and to start the conversation about how they can get connected to the resources and supports within the community that will help address the areas of adversity, whether that is connecting them to websites or community resources that provide parenting classes, whether it is about food insecurity or helping a parent get through a domestic violence situation. So again, it's not that they're saying that the medical home needs to take on solving these problems, it's that it becomes a place to have the conversation and really develop the community network of support and kind of act as the hub to distribute that information and facilitate those connections being made. So I really wanted to connect this to the quote by Frederick Douglass, which is, "It is easier to build strong children than to repair broken men." And I think this is at the core of where pediatric and working with older youth, where that work comes in to addressing the concerns we've learned through the ACES study, which is that the more we can impact how our youth respond to the adversity that they face, and families are connected to ways to decrease those adverse experiences, the better health outcomes we're going to see in adulthood. So what does this mean for the reality of how it's done? SAMHSA has done a lot of work and has some great guides on trauma-informed approaches. And what my hope is, and I can't see the chat box and my screen at the same time, so please feel free to unmute yourselves and chime in. But I'm just curious, how many folks have had experience, trainings, read articles on trauma-informed approaches? Or is this a new topic for people?
Got at least one person in the chat a couple people in the chat now who have mentioned that they have.
Okay, great. It is certainly becoming a pretty common term to hear trauma-informed. Wonderfully, trauma-informed schools practices are becoming more prevalent. This idea of becoming trauma-informed, working with youth, trauma-informed, working in medical settings. And I think that sometimes we get the idea of what trauma-informed is without a lot of nuts and bolts of how to translate that into practice. What we think is that when you start looking at some of the skills you've been learning through SBIRT, they overlap a lot with some of the concepts of a trauma-informed approach. So we're going to try to flesh those out and where those overlapping pieces are. And to do that, I wanted to look at the SAMHSA concept of trauma, which is that it defines trauma through 3 E's. The individual trauma results from an event, which is experienced by an individual and has adverse effects. That is a very broad definition and one that I think is really helpful to keep in mind when you are thinking about trauma. Trauma is not necessarily a set type of experience. It is shaped by how an individual is impacted, how they experience that event, and how it affects them. So when you're working with someone who's experienced a lot of ACEs, it's important to remember that they may or may not experience trauma from the event. And by taking this trauma-informed approach, we're understanding that a person may have experienced some of these, and the likelihood is that they have. And so by looking at how can I meet you where you are, and knowing that I don't know how this event impacted you, I'm going to listen to the individual. I'm going to learn what their experience of the event was. So this is where the trauma-informed approaches of the 4 R's come in, which is when you are trauma-informed, you realize the impact of trauma and understand potential paths for recovery. You recognize signs and symptoms of trauma, not just in the client, but in family, in your staff, and in others who may be involved in the system. First responders are a great example of this. They're impacted by a lot of trauma that they see in their job. And that you respond by fully integrating your knowledge about trauma into every aspect of your practice. This isn't just about how you interact with a person one-on-one. It's about what are your policies, procedures, and practices, and how are they informed to create a safe place with the assumption that you will have people who've experienced trauma come in. This may be looking at what signs you have up, what pictures are on the wall, how the seating is arranged in the room, how they're greeted when people come into the clinic. So this reflects a lot of different aspects, not just one-on-one patient care. And then it resists re-traumatization. So being aware of what triggers could be and how you interact with that. A lot of research when you look at primary care and medical settings in general, we'll talk about how you can do this and ways to mitigate re-traumatizing if you're working with an individual who's been through sexual assault, and really being mindful of practices that support a safe environment. This leads to the 6 principles of a trauma-informed approach to safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice, and choice, and understanding the cultural, historical, and gender issues that contribute to the trauma response. So what I really like about these principles is that these are also principles you're going to have in mind when you're working with youth to have open and honest conversations around substance use and substance use prevention. You're going to create a safe environment to talk about it. You're going to work on increasing their safety. You're going to do that by creating an environment with trusting relationships and being open and honest and transparent. and so on. So I think these concepts map on really well to the work that you're doing with experts. So taking this a little bit further, when you look at ACES findings, what the original study found is that they are very common. 1 in 4 individuals has an ACE, and that this is why trauma-informed approaches are so important. It's that it affects so many people. And by screening, you get a better understanding of that for each individual. And that universal screening is important, that it is not necessarily a subpopulation that is experiencing these events, that it impacts a lot of the general population. And that also is a way to normalize patient experience by having universal screenings. And by understanding the neurological and physical impact of ACEs, that comes back to looking at the physical issues that are presenting in front of you and saying, okay, this was the screening result we got. How might that inform how I create a treatment plan with this patient? And looking at, as you go along, the higher an ACEs score, which the more adverse experience a person has, the greater their score is, being able to say, when you get there, talking to kids about what that creates risks for, so that they know, okay, I've been through this, this is my score, these are some risk factors I need to be aware of, so I need to do some extra work to protect myself. And that can be a great tool to use, to say that we know that these are some things that increase your risk. Let me offer you some protective factors that we can build up to help reduce this risk. And that creates the open window for handoffs and referrals to the community. By building relationships with your patients, they're more likely to follow up on those handoffs, but it's also building relationships with your community and the resources that you're referring your patients to.
So we're looking here at how we can connect the dots, and we'll be talking about resiliency as a way, building resiliency and those protective factors to help mitigate the trauma that kids might have experienced. So what is resiliency? It's the ability to be happy, successful, again, after something difficult or bad has happened. And we're going to talk about 2 ways to build resiliency with youth in a school-based health center, including increasing protective factors and motivational interviewing, and how that fits into our SBIRT model. So next slide. We know that children develop resilience when the effects of protective factors outweigh their risk factors. So if you could imagine a scale, we know that ACEs cause negative health outcomes over the course of a lifetime, but the more resilience that we can build through those protective factors, the more that we can tip the scale towards those more positive outcomes. And I have to share a little bit out of personal experience on this. I come to this work not as a behavioral health professional, but from the field of public health. And I have to say that personally, the more I learned about ACEs, the more terrified I became, because I happen to have a 6-year-old son who, if you were to do a screening on him, would score 4 on his ACEs scale. And for me as a parent, as I've learned more about this, 4 is that magic number where the increase or the risk of potential adverse health impacts over the course of his lifetime increases pretty exponentially. And so for me, I'm really excited to take our focus onto what we can do for building resiliency as a community in our school-based health centers. And for me and my own family as a parent, this is really something that, that drives me fiercely in this work. So on the next slide, here's some key features of risk and protective factors. All people have biological and psychological characteristics that make them more vulnerable to or resilient in the face of potential behavioral health issues. And assessing these risk and protective factors that contribute to substance use disorder helps practitioners select appropriate interventions. We know Rebecca was talking about some of those things that we can do to build protective factors through building strong relationships. And we know that relationships with a relationship with a key adult is one of the key factors for building protection and reducing those adverse effects. We also know that risk and protective factors exist in multiple contexts. They are biological and psychological characteristics, but they also exist in communities, relationships, and society. So targeting only one context when addressing risk and protective factors is unlikely to be successful. And we also know risk and protective factors tend to have a cumulative effect on the development or reduced development of behavioral health issues, underscoring again the importance of early intervention and targeting multiple factors. All right, I'll hand it back over to you, Rebecca.
Great. So what we really want to say is we've given you some background on the ACES study itself, hopefully a little bit on what to do with that as a primary care practice and integrated practice, and what you can do to increase screening and have those conversations with trauma-informed approaches. And then they're the risk and protective factors, and really saying we want to build up the protective factors, because that is what school-based health centers are in a great position to do, is to wrap around individuals early and help to mitigate these risks. And so really the rest of this is looking at how on earth does this all fit back into ASPER. So that clip that we pulled out from Dr. Nadine Burke-Harris's clip really speaks to substance use as a concern in adulthood that comes up for youth with ACEs screenings. And if we know this and you're screening youth for ACEs and you're also screening them for their substance use concerns, you have a great opportunity to connect those when you're doing ASPER and to present them with some of that information and help them make choices to increase the protective factors, and also provide the patients and their families with those connections to community resources. So it all starts with screening. It starts with screening in ASPER, it starts with screening with ACEs. And by doing this, you're opening the conversation and you're decreasing stigma all the way around. And then you have the opportunity for your brief intervention in ASPER. And this is often related to motivational interviewing. So you're going to meet the patient where they are. This strengthens your relationship. You're going to reinforce the positive things, not only with their substance use, but in their lives. And when you're doing this, you're reinforcing the protective factors already at play. So maybe they mention a coach that they get along with, or maybe they talk about a church group that they're involved in, or they talk about an art project that they just finished. That's an opportunity to really build on protective factors. It's also a chance to provide them some education. So in this brief intervention, asking permission to offer them some information about how the tough experiences that they've had could impact their health in adulthood. And we know that youth are not great at making that long-term connection, but putting that out there, providing information so that there's some context. You may not be experiencing a lot of negative impacts from your substance use right now, and I want you to be aware that this is something that you could be at risk for later in life. Can I give you some more information? And then you build on the strengths that you've seen with them, and this draws on your relationship with them. All of that, also when you're looking at what referral to treatment looks like in the ASPER process, referral to treatment could very much go hand in hand with how you're going to help them address their ACEs. Maybe that referral is a warm handoff to a behavioral health provider. It could be on education and skill building around things that are going to help them manage the stresses in their life that may ultimately decrease their chance at increasing substance use. And then also looking at how can you support their family and their network to get the skills that they need to reduce the presence of negative adverse experiences in their life. So where do you fit into this? Really looking at taking off your shoes and stepping into the patient's role and understanding all of this from their perspective by being curious, by asking. And so before I go through all of this, I wanted to pause because most of you have done quite a bit of motivational interviewing training and work with SBIRT in general. And I'm curious at this point, what overlaps are you seeing of how you can bring a trauma-informed practice into your SBIRT work? So I'd love to hear from people either in the chat box or unmute yourselves. Really like to get your perspective of how you think you're already doing this, because you are. And so what I'm thinking about within this is when you start, especially going back to those critical motivational interviewing skills, making a trauma-informed context for your motivational interviewing. So really, how are you drawing out strengths when you're talking to your patients? How are you finding out about the relationships that support them in their lives, or connecting them more to those resources in your community?
And Rebecca, we do have one comment so far that says trust and relationship building is the foundation of trauma-informed care, and this is the only way a meaningful SBIRT process can go forward.
Absolutely. And that really is where I think the overlap is. Any other thoughts? So within that, these are some of the things that came to mind when I was putting this together, of how these two concepts pair together, of being trauma-informed and using SBIRT, which is you are going to ask. You ask permission. That creates safety. When you are asking permission to discuss a topic with a patient or to offer them information, you're not only building trust, but you're making it a safe place. And that non-judgmental atmosphere also creates that safety. It also brings curiosity, and that lets the patient feel empowered. It lets them be the expert on them, because they are. And then bringing the understanding of, okay, this is your experience. Now let me give you some information of what I know, and being able to educate them on how ACEs can impact them and what they can do. So really encouraging them. I want to just appreciate what Christy said about that. I think there's a lot of fear sometimes when we look at the research on ACEs and saying, wow, that is not a good outcome. When you start to see ACE scores go up, it's scary and it can be a little bit daunting. And to be able to shift that conversation back to, so what can we do? How can we support you to increase those protective factors? And really understanding that those protective factors to help with ACEs are the same things that are the protective factors against substance use. And that is a foundation that you can help them see the connection on, and then help facilitate how are they going to link to these things. Or in your motivational interviewing, how are you going to help that patient articulate what they're good at, what their strengths are, who their supports are, and what healthy can be for them. And that is really the collaborating piece. So understanding where your patient is, and then building on that. And if you can, especially on the younger end, but really whenever it's possible, including the family in that collaboration too, so that you make sure that you're not only connecting the youth you're working with, but their network to whatever community resources that you can provide. And especially on the younger kids. I mean, we might not be screening a 6-year-old with Asperger's, but still taking the same idea of how can I have this conversation and work with the family and use those motivational interviewing skills that you use in Asperger's to help them address and get the resources they need to build up the protective factors for their kids. So it really is, I'm going to agree wholeheartedly with the comment that you shared from the comment box. It is about building relationships, meeting patients where they are, and then moving forward together. So with that, a trauma-informed approach helps you identify adversity, normalize experiences and body responses, and increases opportunities to strengthen protective factors through positive relationships and referrals. So this next part that we have really is saying, when you're looking at these two different screenings, the ACES screening and the Just Health and Craft screenings, how can you use these? So in ACES, these are some questions that you might be able to ask with the screening. Who is someone that you can go, that you can trust and go to? What's something you're good at? What is your hope for yourself in the future? And how do you know if you're stressed or upset? As I'm reading through these, I hope that you guys are seeing that these are very similar to questions that you might ask when you're responding to Just Health and Craft screenings as well. And that going through those, you can also look at those and say, where am I seeing protective factors in place already? What answers do I see in these screenings that I can feed back to the patient to help them come up with these answers? And that is, for me, that's about the information we have to share. Before we get to questions, I do want to open it up again just to anyone who has any case examples that they'd like to share where they've seen successes with this approach, how that they might be thinking, oh, I've done this. I do this all the time. So I'd love to hear what it looks like in practice on the ground in clinics, if anyone would like to share.
And if anybody would like to share, feel free to unmute yourself to tell your story, or type the case example into the chat box.
I joined late. This is Jen in Montrose, so I don't know if it was covered, and I didn't even hear the whole question, but we've been using both screening tools, and I think the ACES screening, and particularly the resiliency questions at the end, open up a really nice way to focus on positives with kids who potentially have a lot of negatives that they're facing and experiencing. And they may even view their own situation in a really negative light. And so I really like that aspect of the ACES screening tool, and it gives you a lot of good insight into the kid and can help shift to a positive much easier than sometimes just in guiding the conversation you can.
Thanks for sharing that. Let me go back and just mention the questions that I have listed here on the slide under the ACES screening. These are the 4 questions that come at the end of it that are the resiliency questions that are asked. So the questions that Jen was referring to, those are the ones that students are seeing and able to respond to at the end of the ACES screen on the APACS app at present. Does anyone else have anything that they would like to share about how they're using a trauma-informed approach or bringing in a discussion of increasing protective factors to their SBIRT work? So what I really wanted to emphasize with this is that I think that this is information that has been shared out pretty widely over the last few years as far as the awareness of being trauma-informed, and our hope is that we're giving you some tools, some ideas to put that into practice, but also highlight where it's already happening naturally in your practice and how SBIRT as a framework really facilitates a trauma-informed approach. And also being able to share with students and their families why talking about this matters and why building those protective factors matters. So if there are questions that people have on this, we would love to give you guys an opportunity to ask those. Fire away.
And if you have questions, feel free to unmute yourself to ask or type them into the chat box.
And I'm just gonna scroll to the last bit, which is the references page, if you guys are thinking about any questions. But I just wanna highlight on here that some of all the frameworks, the video, everything that we referred to in the presentation, the links are available here at the end. And I'll slide back to this one. If questions do pop up for people and you'd like to reach out to us, that is the contact information for myself and for Christy. I sped through things a little bit at the beginning, but I have been hoping to see the Resilient School Communities work to the end, which has been a lot about resiliency and how to build that within a school setting. And Christy, as she said, she's been involved with the ACES work that Casbit's been doing, as well as the STEP work on tobacco prevention. So those are, you can reach out to either of us with any questions you might have, and our contact information is there.
Great. Well, if there are no questions, we will be happy to share the slides with the group, if that's all right with you, Rebecca and Christy.
Absolutely.
Great. If you haven't already, please make sure to enter your name, agency, title, and email address into the chat box. I'm also going to post right now a link to the post-session survey. If you would, please make sure to fill that out. It's a quick survey on SurveyMonkey. Otherwise, thank you, Rebecca and Christy, for being here and presenting on this important topic. We'll leave the chat open for a little while here so folks can both get the link to the survey and type in their name, agency, email address, and title if they haven't done so yet. But thanks everyone for being here today.
Thank you, everyone.